Hello, myself Dr. Ravina Kalyan, Faculty of Physiotherapy Department. Welcome to our YouTube channel RPIIT Academics. If you like the content of this channel, please do not forget to subscribe and share the content. So in the last presentation, we'll talk about the introduction of the respiratory failure, its causes and clinical features. Now in this presentation, we'll talk about the management of the respiratory failure. So management include prompt diagnosis and management of the underlying cause is crucial. In type 1 respiratory failure, high concentration of oxygen, that is 40 to 60 degree by mask, will usually relieve hypoxia, but occasionally mechanical ventilation may be needed. Acute type 2 respiratory failure is an emergency. It is useful to distinguish between patients with high ventilatory drive who cannot move sufficient air and those with reduced or inadequate respiratory effort. So first is control of primary disease. For example, antibiotics for chronic bronchitis or fulminating pneumonia. Second is maintenance of patient airway, that is nasal catheter to remove secretions and stimulate expulsive coughing. If secretion cannot be cleared by simple means, tracheostomy or endotracheal tube. Third is oxygen therapy, and the aim of oxygen therapy is to control hypoxemia without allowing CO2 retention to threaten life from respiratory acidosis. And this can be achieved by low concentration of oxygen, that is 1 to 2 liter per minute, by nasal cannulae or calibrated venturi mask, and titrating PaO2 to 8.0 to 9.3 kilopascal. And high flow systems increase effect of inspired oxygen concentration, that is FiO2. Next is continuous positive airway pressure can be added via tight fitting face masks to recruit collapsed alveoli and improve gas exchange. And when oxygen system fails to sustain adequate PO2, further interventions included are intubation and mechanical ventilation. Fourth is the treatment of acidosis. It is treated with intravenous soda bicarb. Acidosis corrects itself if adequate alveolar ventilation is maintained. And the fifth is treatment of failure of ventilation by mechanical ventilatory assistance. Indication for ventilation are increased respiratory rate, asynchronous respiratory pattern, altered mentation and conscious level, frequent oxidation desaturation despite increasing oxygen concentration, hypercapnia and respiratory acidosis, circulatory problems including hypotension and arterial dysrhythmia. And the non-invasive ventilation NIV is the provisional of ventilatory support without instrumentation of the airway, and it can be achieved with positive pressure administered through a well-fitted mask. And the criteria of non-invasive ventilator in hypoxemic respiratory failure is dyspnea and respiratory rate is more than 30 breaths per minute. And invasive mechanical ventilation, that is mechanical ventilator provide a substitute for the respiratory muscle pump. Thank you.